Hiatal hernias are also called diaphragmatic hernias. They're protrusion of the stomach through the esophageal hiatus of the diaphragm into the chest. It may be asymptomatic or have symptoms that are very similar to GERD. They can be two different types. They can be sliding or paraesophageal, where they're rolling, where they as you can see from the picture located on page 890, or excuse me, on page 1092. Um, get there. You can see here you have the esophagus. Where's my little flipper? There he is. You see the esophagus and it goes through the diaphragm. Okay, this is what the normal stomach looks like. A herniated portion of the stomach is where it comes back up through there. So it's a sliding hernia. Sometimes it's up, sometimes it's not. The rolling hernia is where there is a herniated portion of the stomach that stays up there all the time. A sliding hernia sometimes will be above the diaphragm and sometimes it will not be above the diaphragm. There is a nursing action alert on page 1093. It talks about the most important role of the nurse in caring for a patient with a hiatal hernia is health teaching, to encourage the patient to avoid eating in the late evening and avoid foods associated with reflux. So it's also about teaching about positioning and to sleep at night with the head of your bed elevated at least 6 inches. Remain upright several hours after eating. Avoid straining or excessive vigorous exercise. And refrain from wearing constrictive clothing. Doesn't that sound like a select all that apply? Again, that's the action alert box on page 1093. Another one of those is the key features in chart 54-4, where it talks about both the signs and symptoms of a sliding hernia and the paraesophageal hernia. They have different, as you can see from the, they're very different. The sliding hernia has more of a heartburn, regurgitation, can have chest pain, trouble swallowing. The paraesophageal is more of a feeling of fullness. They'll sometimes get breathlessness when they're trying to eat. Their chest pain is worse than that with the hiatal hernia. It almost mimics that of angina. And it worsens when they are in a recumbent or a laying down position. Again, that's chart 54-4. So when you're assessing a patient with hiatal hernias, you want to ask about heartburn, regurgitation, pain, trouble swallowing. So it's a lot of the same questions you ask when someone has GERD. You want to talk about the nutritional status. You want to talk about do they know the location of their hernia, the onset, duration, when do they have pain? Are there certain things that exacerbate it? What are some things that help to relieve it? The diagnostic tools are they usually do a barium swallow study, and that's under fluoro. And again, it's very similar to when they do a barium swallow study to see the regurgitation with the when you're looking at a hiatal hernia, it almost goes from like a big to like a squishy little smaller, and then it goes back out. So it's interesting to watch the barium go down. There's all kinds of YouTube videos on watching the barium go down on a barium swallow. It does kind of give you a pretty good idea of what's going on in there. And here is your slide on the nursing interventions for hiatal hernia. Again, the most important role is health teaching. This is all off that action alert on page 1093. You want to make sure that they avoid late night eating. Weight management is very important to make sure that they're elevating their head of their bed to sleep. Remember that said 6 inches. Avoid straining, and you don't want to use tight-fitting clothing either. So a lot of times if patients are going to have surgery for their hiatal hernia, pre-op, they need to lose weight and quit smoking. A lot of times they will not treat a hiatal hernia, and especially for people who are morbidly obese, they have to be below a certain weight in order for them to have the surgery done. There are many different procedures. Post-operative care, you look for the risk of bleeding. Other postoperative complications can be seen on chart 54-6, and that is on page, excuse me, that's on page 1094, page 1094, postoperative complications. And if you look at it, though, really your postoperative complications are going to be, things you would expect to see. They're going to have temporary difficulty swallowing because when they've had the endoscopic procedure, they're going to have had a big tube down their throat. They're going to have gas and bloating because when they're looking for things, they use air to move things around. So a lot of times they use a lot of extra air when they're having an endoscopy procedure done or anything under fluoro. They may have some atelectasis or pneumonia from just not being able to take good deep breaths. They may have some nausea and vomiting from the nasogastric tube and from the discomfort. The patient experiences nausea and vomiting and abdominal distension, and the nasogastric tube does not drain. So a lot of times they'll use a nasogastric tube if they're having trouble getting out a lot of the excess air, especially when they do an endoscopy, if they've had to use a lot of air, they'll put down an NG tube while the patient is still sedated and let a lot of that air escape prior to the patient being completely awake. Postoperative instructions or post-procedure instructions for both the paraesophageal repair and the lap Nissen procedure are there on page 1094 as well. It talks about making sure that they're not lifting anything heavy, just normal surgery stuff. There's not a whole lot that is specific to this surgery. They do want them to remain on their anti-reflux medications for at least a month. So that's all we're going to cover in this chapter today or for this exam. So it's going to be important for you to look at GERD, chronic GERD, and for hiatal hernias, know the different types, and for both, make sure you know the nursing interventions.